I've been interested in the genetics and genomics of multiple myeloma for a good part of the last 10 years. And during the presentation, I will present some classical data on multiple myeloma genomic profiling, as well as new findings that are related to the opportunity of therapy personalization in multiple myeloma. So I would say that the most striking finding about multiple myeloma in the era of genetics relates to its heterogeneity. So when we can find gene mutations at the whole genome level, we have realized that multiple myeloma is heterogeneous both in time and in space, in the same patient, and of course across patients, which makes it a very tough disease when it comes to personalized treatment and prognosis. Certainly, though, the wealth of information provided by genomic data is a resource in the setting of multiple myeloma, and we want to exploit this as much as we can. So I would say that as of today, the genetics of multiple myeloma are relevant for disease classification as much as they were 10 or 20 years ago in the era of FISH. Novel insights from genomics in myeloma haven't really upgraded the cytogenetic classification of multiple myeloma, and they have not provided new prognostic information. What we know is that in the era of novel agents, there are plausible gene targets of such treatments that may be mutated upon treatment, and these may explain resistance. We believe that this is actually the mechanism of resistance in the minority of cases, because in a recent study where we looked at proteasome inhibitor and IMiD-resistant multiple myeloma cases, we didn't find a great deal of target gene mutations. Rather, we found that the genomic profile of these resistant cases was much more complex than what we find at diagnosis, and these cases were enriched for high-risk lesions. So I think that the focus of myeloma genomics today is the identification of high-risk cases, which is something that is only partially captured by current prognostic algorithms that are mostly relying on laboratory features. Among ways to predict a high-risk patient is to look at patients that would relapse early on treatment. So early relapsing patients are patients who fare much worse than the average overall in the disease course. And we have recently identified some genomic features such as P53 mutations, MYC gene rearrangements, especially translocations between IGL, the IGL locus and MYC that correlate with a higher probability of early progression on treatment. Subsequently, we have started to profiling multiple myeloma patients from a genomic and a transcriptomic point of view. And this is a big deal because we now have a new drug that's highly effective in myeloma, and that's called Venetoclax. That's a BCL2 inhibitor. And surprisingly, it works very well in a subset of patients, whereas it's detrimental in the other patients. So it's crucial to identify patients who will respond and who will benefit from drug treatment. The others will be harmed by treatment instead. So we know that cases with translocation 11-14 respond well to Venetoclax, and that's the most widely used biomarker so far. Nevertheless, we do have nowadays evidence that at the RNA level, we can profile patients based on their likelihood to respond, and using RNA sequencing analysis on hundreds of patients, we have identified additional genomic lesions, such as deletion of the CYLD gene, as a strong predictor of high BCL2 levels. And we have validated these findings in silico using publicly available drug response databases. And we know that cells that have a CYLD deletions would respond well to Venetoclax. So our findings really support the use of extended genotyping in multiple myeloma and the creation of large databases of DNA profiling, RNA profiling, and clinical information to support the development of personalized treatments in multiple myeloma in the coming future.